something came up in our discussion, which was going to come up anyway, which is the HTC, right? Which is the Hemophilia Treatment Center. What the heck is that?
Well, there are about 140 of them in the U.S.
Okay.
And I could say they're just awesome. I mean, every hemophilia
Heck of a
patient.
definition.
I know. We'll take it. Yeah,
I mean, every hemophilia patient should be associated with one. Like in our center, for instance, we have a group of hematologists. We've got a couple physician assistants, 3 nurses, 2 CMAs. We have a physical therapist. We have an onboard social worker. And we're fortunate that we have an in-clinic pharmacy. And I have a couple, a pharmacy technician, a business manager. We have a person who does research for us. We have data collection people. We have a program manager. We have someone who does all of our appointments and scheduling. I mean, it truly is awesome what the
It's a full, I mean, you know, the whole terminology now is medical homes, and hemophilia has had medical homes since the mid-'70s. And so we've been doing the same, you know, what everybody else is trying to do for decades.
Now, you said there were 140 of them, right? It's a big country.
Yeah.
140 is pretty dilute.
Yeah.
Are they accessible to people with hemophilia who can't get to them? Where are they located? Give me the skinny on
Well,
this.
they're normally in the big metropolitan areas.
What
so
a
there's
shock.
One,
What a surprise.
I know,
they're normally, we have one in Philly, and there's one in Baltimore. There's one in Morgantown, West Virginia, Pittsburgh. That's the area that I work within. My pharmacy works a lot with the Colorado HTC because we have Colorado Medicaid at my pharmacy. And that one's great. Each patient has their own nurse. So when you call, you ask for that nurse, and you know if you have a question about a prescription, you can talk directly to her. And they have, like I said, dentists, physical therapists, everything all in one. And people who actually go to a HTC have a 40% reduced mortality rate than patients who don't use an HTC.
Let's just stop there, because that's an astounding, I did not know that. 40%.
Well, they're experts.
But that's ginormous.
Makes sense, right? Yeah.
I mean, yes, that's ginormous, which brings the other question obviously to the fore. Who can't get to them?
Yeah.
And we do have patients that can't get to an HTC. We had one patient that was homeless and was living out of his car. But we have patient reps with my pharmacy, and they'll cover a certain area, and they do in-home visits and check on the patients. And his rep actually physically took him to the HTC for his appointment because he didn't have access.
But think about all these rural areas. You know, we're all from relatively, you know, big metropolitan areas, but states like Montana, and they have very little, you know, it's hard to attract physicians to go there for hemophilia care when there may not be that many patients. And so those patients have to go to places like Colorado, multiple states over. And so, and you know, because of the issues of the HIV and hepatitis, some patients left that community and never came back. And we're hoping that the next generation will see the benefit of the HTCs. And you know, we'll have less people taken care of outside the
It occurs to me, this is a great opportunity for telemedicine. At least getting advice and interacting in some way.
Sure.
Is this happening?
Yeah, I mean, we were actually, our center was asked to, because of our good track record of treating patients, our local Blue Cross group was kind of looking for that very thing.
Yeah, and there's a couple centers that have trialed this out, Roshni Kulkarni and Michigan State. So Michigan has these areas up in the Upper Peninsula, and they've been utilizing it. It's fantastic. You know, people are looking at their joints on the TV screen, and you know, it's all trying to figure out how we can make sure we get reimbursed for our time, and at the same time, we obviously want to take care of the patients.
Right. I mean, there's 2 separate silos here.
Yeah.
Right? Reimbursement is important.
Yes.
But also patient care.
Yes.
And from the patient care perspective, what I'm hearing is this is great stuff.
Yeah.
Now let's let the business people work this out.
Yeah. Right. Yeah. We have patients send pictures. We have the dedicated email where they send pictures if they said, "Oh, Johnny fell and hit his head," and you know, I'm on the phone. I don't know what that looks like. Sometimes just send a picture. And so we've been doing that, and we start including those in the charts, and we talk to them later about, you know, for that I probably would have given a higher dose than you did. And so I think it's nice that we have that.
You could put the disclaimer, usual text messaging rates apply.
Yes. It goes to a separate email that says, auto reply. We're not responding to this immediately.
Got it.
Yes.
Now, we've been talking about pharmacologic response in terms of pharmacists, but pharmacists do more than that, right? They can cover all sorts of areas of patient care.
Well, I think what we can do is we're really the kind of the eyes and ears for the kind of the rest of the care team.
Okay.
Because the patients, if they're on kind of prophylactic treatment, they're going to be calling once a month, or we'll be calling them once a month. And we really get to know them, get a sense of what they're doing. So there's a series of questions that we'll all ask is, how many doses do you have left? And it kind of gives us a guide as, okay, how many did we dispense last month? We can kind of take a look at that quickly. And it gauges kind of their adherence to their treatment. Have you had any bleeds? Did you have to treat extra for those bleeds? And kind of what did that look like? And sharing that information back to the care team.
You're not just renewing scripts here.
Yeah.
No. We like to think we do a lot more.
You probably do.
Yes.
What is, if you were going to pick the one thing that you do that most lay people would think would not be the pharmacist's purview, what would that be?
Well, like Tim was saying, in hemophilia pharmacy, we're really important because we check in with the patient every month. And that doesn't always happen.
Yeah.
You might see the doctor every 6 months, every month. So if a patient's really struggling, having a lot of bleeds, the doctor may not know that. So we can make an intervention and say, hey, he needs more bleed doses, or do you want to increase his dose? Should we increase the frequency? And make that kind of recommendation. They might be exercising more and they need more bleed doses. So the doctor might not know that. So just touching base with that patient every month is a good thing to let the doctor know.